the IPV conference. We had a jam-packed day full of exciting new information, and I am going to tell you all about the public health track. But first, I want to hear about the two other tracks. So Michelle, off to you first. Please tell me about your day.
So, wow, what an amazing day. I am going to give the overview of the basic science. I missed session 1 because I was moderating an early career researchers first session that was entitled Breaking Down Silos and Enhancing Cross-Disciplinary Collaborations. And I hope all of you, regardless of your career stage, will take time to review this session. The advice was fitting for everybody, and the session was really inspiring. But I did go back and watch the basic science sessions. And honestly, every talk from every session was really outstanding. I really recommend that you take time to watch all the talks if you haven't already. I had a really hard time deciding on the talks to highlight. So my disclosure is that my choices are not without my own bias. Topics that I find exciting, methods that were really interesting. And I also disclose, even though I covered a lot of immunology, I'm not an immunologist. So I really appreciate those speakers that made things accessible. I also am really trying to highlight talks from young investigators. So in the first session, there was an abstract from Nicholas Tessier and colleagues that describing a study that addresses an important gap in the knowledge, describing the local immune responses during an acute HPV infection. And most of these are cleared, and we really don't know very much about this at all. And I think it's really important because a better understanding of the immune response that promotes clearance could really help us inform therapies for those infections that persist. Abstract 581 from Toby and colleagues showed that high-risk HPVs can block the gas sting pathway. I think this is pretty novel, and it was a really robust study because they tested multiple high-risk HPVs, including 18, 16, 31, and also used really relevant cell models that are important for infection. Yin and colleagues used a really powerful platform, innovative platform, really cool technology to investigate how E6 proteins from high-risk HPV 16 and low-risk HPV 11 alter keratinocyte homeostasis. So that was pretty cool. In session 2, which was virus-host interactions, there was really an excellent talk from Mary Bedard and colleagues, where they have a really powerful look into juvenile onset respiratory papillomatosis. They had a 20 patient cohort, and they showed really compelling evidence, even though only 2 of the patients had HPV 11, but these patients had much more severe disease. And more importantly, they established a pipeline of patient-derived matched non-disease and RRP cell cultures and raft models of infection to study. And I think this cannot be overstated because nobody's really been able to do raft cultures of HPV, of low-risk HPVs. And so this is going to bring about a lot of new information. And they also did some really cool RNA-seq that was kind of preliminary, but I think it's off in the right direction. The last session was the second immunology session. Very nice session. There were 2 talks that focused on novel finding of a co-stimulatory T cell receptor, CD28, that plays an important role in controlling skin HPV infections or skin papillomavirus infections, because they use both people and mice. And I think the extension of these studies are bound to be really revealing about controlling papillomavirus infection. And there were also 2 interesting talks using mouse papillomavirus type 1 to develop beta HPV models for infection and L2 focused vaccine testing. And then an abstract that I thought was really cool was from Haitian colleagues, where they studied the potential function of a conserved longer L1 isoform in high-risk HPVs. And they used a really cool, innovative preclinical model of the mastomyce. I'm going to screw up the words, but it's the Mastomus coucha mouse. And the species matched MNPV that causes skin tumors. And their data suggests that this long isoform of L1 is immunogenic, but that vaccination with this isoform doesn't protect. And it supports the idea that it might be a decoy to induce non-productive antibodies to favor immune escape, which I think is really super interesting. And then lastly, that sort of fits into some of the other clinical sciences, Jennifer Gillis and colleagues find that functional memory B cell responses after challenge with the non-valent vaccine in girls that received 2 or 3 doses and women that received 3 doses of quadrivalent vaccine, they found no difference between the groups. And I think this really reaffirms how robust and durable the HPV vaccines are. So overall, my recap on the basic science is wow. Congratulations to all the authors. And Barbara, what did you find exciting?
Well, my day was equally excellent, I have to say. And I have to say, I'm really jealous that I didn't go to all your basic science sessions, but this is the beauty of having a Zoom meeting that tomorrow you can go and rehash all the sessions that you missed because you were attending another one. So there are the silver lining in the clouds. I'm going to start with the absolutely fantastic plenary session that really blew my socks off, I do have to say. It was started off with Bob Garcia, who looked at a single shot using a very unique, it was a unique collaboration with bioengineerings to create a thermostable, slow-releasing vaccine. And that was then covered by something they call an atomic layer deposition technology. This sounds like something, you know, right out of a very good sci-fi movie.
You sure? Yeah.
I
Rocket
know.
science.
It was totally rocket science. But it was amazing. You basically kind of spray, freeze dried these capsimeres from HPV. That's where the antigen is. And then they began to cover with layer after layer after layer this alumina, you know, so it basically created like a little capsule that kind of slowly deteriorates and slowly releases the antigen. I mean, this was just like amazing. And
Prime
you know, right
plus
now,
boost in one shot. It's amazing.
yes, it was amazing. And so the data was given for, you know, mice right now, but obviously they're kind of moving into human models. So this was really exciting. And they can do also numerous HPV types into a single model as well. And then George Vandenberg also gave a great talk looking at the importance of infiltrating myeloid cells. And what they looked at is, you know, basically vaccine response like into recalcitrant, you know, cervical cancers. And when they were looking at not only giving chemotherapy, but this adjunct of the vaccine, and his studies took this deep down dive into why some of these women were not really responding as they expected. And what they identified is that there are these myeloid cells that are basically immunosuppressive. So you have to give the vaccine kind of after you start suppressing the myeloid cells through chemotherapeutic agents, and then you give both of them at the same time. And they were able to then show that these individuals could respond with, you know, HPV immunological responses. So both of this was really exciting because it was showing that we need to know how to use these therapeutic vaccines in conjunction with chemotherapeutic agents. So I'm going to go back also. I was also had to go back and watch some of the morning sessions.
You know, Barbara, I wanted to comment on the plenary because the third speaker, Maya Goldenberg, who touched on vaccine hesitancy, I found her talk to be super interesting because she talked about like kind of the long held preconceived notions that so many people have about why parents hesitate or why people hesitate. And those were some of mine as well. And so hearing her come from that kind of psychological research background really made me rethink the way I think about why people aren't taking these safe and efficacious vaccines. So that plenary was all three speakers amazing.
Yeah, I know, and thank you so much for reminding me, because I was going to say, and Aimee will cover public health vaccine hesitancy that the third speaker was, since the two were first more clinical. But thank you for reminding me. It was great. And I'm a vaccinator of kids, and I deal with parent vaccine hesitancy on a regular basis. So I appreciated that.
Sure.
Wanted to talk about starting off with the clinical sessions. I thought there was a really exciting one that was done by a Dr. Faden, an early investigator, who talks about the circulating tumor DNA, which is Hpv DNA, which is now being used kind of diagnostically, both before as well as diagnostically after head and neck diagnoses. And basically, his data suggests that maybe we can replace tissue biopsies for actually confirming that that individual has a HPV-associated head and neck cancers. So that was, I think, super exciting data. Also, Dr. Aimee gave another one looking at dual staining and its prognostic in oral cancer survival, but also distinguishing the, quote, HPV or the P16 negative. So they really show, again, best survival, P16 positive, HPV positive, worst P16 negative, HPV negative. But then they were in between and really showing that we can't lump all the HPV negatives even together, nor the P16 negatives. So that was, I think, really critical in how we're going to be able to home in more, not just looking at P16 alone, but looking at the 16 and the HPV together. So another one that I thought was moving along, I thought there was another one that was really great, is Megan Clark gave a talk about the relationship again with obesity and cervical cancer. And it is, I mean, we kind of know this, but it was really an elegant study that once again says we got a problem when we have women with abnormal cytology or cervical cancer screening in an obese. And it's probably, a matter of not really visualizing the cervix adequately, not be able to then treat those women. And so we're seeing increases of invasive cervical cancer in this vulnerable group. So I think it's really an important way that hopefully HPV testing will help us, but it's still not going to help us do that deep down dive and actually adequate treatment. Another session I thought was really great, Dr. Ozbun, who always gives these great studies and talks to us about verification bias. This was once again great. He did something so simple. It was like, let's compare VIA to, HPV testing. And it was amazing. It's all how you slice and dice it. But when you use just, colposcopy directed biopsies, VIA actually looked as good, if not a little better than HPV testing in its sensitivity. But if you did the random biopsies, right, if you actually throw that in and you really make sure someone has something or not, high-risk HPV testing came on top. So once again, it just really underscores how our epi studies are affected by verification bias in itself. Some other studies that I really thought were worth also talking about in some of the later sessions, and I went to the late breaker as well as my last session, went back and forth, made myself a little dizzy. But one of it was by Dr. Thompson, and that was looking at extended genotyping. And we're beginning to get a really good flavor about how important this is, but it really critically showed that 16, 18, 31, 33, 45, 52, 58, they are in a different league. And then you have the 35, 39, the 56, 59, 50, and 68, they're just not behaving anywhere near. So when we're lumping all of our high-risk HPV into non-16, 18, we're probably not doing women any good. And so that was really great. Another one.
This is also a cool thing because there needs to be some basic science on this to figure out what is different about it. Like,
You're so right. Yeah.
That interplay is critical. It's how we move. Yes, it's how we move the science forward.
yeah, cool. Sorry, I interrupted.
Not at all. So then another one was by Dr. Xing. It was a late breaker, and it was all about the study in Costa Rica and the bivalent, but it was so cool about the unmasking. That is, when we go in and we treat these nasty HPV genotypes, we also treat the transformation zone. We also treat women who have other types. Suddenly we're not treating as many women, that's yay. But then we have all those other types that are hanging around. And the study actually demonstrated that unmasking is probably real, that we are going to end up with more non-vaccine, HPV lesions, and we're going to have to face that. Now, we don't know whether those are much more likely to go off to cancer, as I just talked about.
Yes.
So, how we interpreted that, we still need some really good longitudinal studies. And
again,
I thought that one was
basic science that could be done to help us figure that out. Sorry, Aimee.
Absolutely. No, good plug for basic science. And I thought that one is interesting because it's something I feel like our community has wondered about for, more than a decade, since the vaccines came out. And so to see proof of concept is always fascinating, but then also to kind of hear it put in the public health context of like, the vaccines are still doing great. That's the big picture, but we still have to pay attention. I thought was great context.
And my last one was Dr. Barnabas, who talked about the one dose. We were all holding our breath on this one. And bottom line is the vaccine efficacy looks really good. Now, it's over 18 months, so long-term data we're going to need, but that was a thumbs up on that one. So anyway, it was really exciting day, and I'm going to turn it over to Aimee to talk about public health.
I agree. And I think the work by Dr. Barnabas is the first of many results from clinical trials that are coming out at this conference. So before that you're seeing them in these high impact publications, you're getting a first glimpse of the findings. And to me, this is one of the key reasons I attend the conference, is because you get the information first and you get it from, the PIs. So I loved that. And I'm excited for Friday, because I know there are several more one dose talks where it's the first release of the data that are going to come out. So let me tell you about my day. So we cheers. So the public health track kicked off with looking at the impacts of the COVID-19 pandemic, because we can't talk public health without talking about what COVID-19 is doing. Dr. Laia Bruni continued her research theme, which she has been pursuing for so many years now, that is so informative, which is this global view telling us what is going on in the world as it pertains to vaccination. And what she continues to show is that the countries who have the greatest need for cervical cancer prevention have the lowest HPV vaccine uptake. The numbers are it's unacceptable. 15 years after introduction of these vaccines, they're safe, they work, and we can't get them to the places that we need. And so she then told us what the COVID is doing. And in many places, that we're able to get at some decent level of vaccine uptake, this is tanking. So she cautioned that we need to organize how we're going to catch up now. And she talked about how 14-year-olds are going to age out. They'll be unprotected. The 9-year-olds have still some time. So she's giving us some guidance on how to think of these strategies to kind of recover from the cervical cancer prevention perspective during a pandemic. Alex Vorsters put forth an interesting example of Ethiopia, because they actually did quite well and gave us a great example of a low or middle income country that was able to react during the pandemic and maintain high HPV vaccine coverage. So I appreciated that. Moving on, we heard a lot about Hpv natural history across many anatomic sites. One of the ones that I wanted to comment on was one by Dr. Wei. She did a pooled study looking at anal HPV incidence and clearance. And this was in HIV positive and negative. And this kind of gets to one of those methodologic issues you were bringing up, where when you pool studies and you look at their quality, you really can reap the benefits. You can get power from that. And so she was able to classify kind of who has the highest incidence, lowest clearance with more precision that we're usually able to see. So I thought that was a great one. We also had screening talks today. Following up on your comment on some of the dual stain work, we heard similar messages. We're seeing that there's high consistency with dual stain across studies, and that maybe, you know, it's going to edge out cytology because of the heterogeneity in that. And that there's just
I thought cytology was already edged out. Oops.
Well, the data keeps coming. And so what else? We also heard some results from the Estaba Study, which is a large screening study throughout Latin America. And that was, again, talking about, you know, with, you know, how to use PAP, how to use HPV testing. And what they saw in the Estaba, and this is work done by Dr. Ramirez, she showed that PAP that was interpreted with knowledge of HPV positivity was more sensitive than PAP without knowledge. But she went on to say that that gain in sensitivity was actually limited and variable. And so she said that sustained efforts need to focus on switching to HPV tests as a screening test, and that the limited sensitivity of PAP as a triage suggested other candidates should be considered. So again, one of these, you know, very big studies, multi-country, kind of giving us information about how to move forward our screening practices.
And I didn't mention, but there were several methylation studies looking for that triage test, which can be done without having cells. So you don't have to do it on PAPs, which is a great thing, but they're still working on them.
Definitely, definitely. We then went into several vaccination sessions. Vaccination was a big part of our day. One of the studies that caught my eye was by Dr. Sparin, where he was looking at safety as it relates to pregnancy outcomes. And so even though we've had these vaccines for 15 years, we know they're safe, we know their safety profiles, it's still important to keep our eye on the ball. We still need to monitor safety, you know, because it's only when, millions and millions and millions of people are vaccinated that we can really get at maybe some of those other smaller signals. So anyways, Dr. Sparin put forth very reassuring data in a study of nearly 500,000 women where they were having pregnancies, and showed that HPV vaccination resulted in no increased risks of preterm birth, neonatal mortality, any kind of the outcomes we'd be interested in. So again, you know, we continue to get these reassuring results as it pertains to safety, which is important. We also saw, when we talked about vaccination, we saw a great example of its success. We saw a talk by Dr. Peter Sassini, I think is his last name, and he showed age-specific rates of cervical cancer in England by birth cohort. And what he was able to show in a huge population is protection from HPV vaccination against cervical cancer. So remember, when these trials were done, they did protection against precancer, and then we moved down to virologic endpoints. And I think that was good enough for many of us. I mean, we believe HPV is a necessary cause of cervical cancer, but nonetheless, we want, you know, cancer is what we care about. We want that cancer endpoint. And so we're just starting to see the first few studies where we're seeing cervical cancer as an endpoint and seeing how the vaccine works against it. And it's taken so long just because cervical cancer takes time to develop, you know, so that's why we had to wait, but the results are coming in and they are marvelous. What they're showing is tremendous reduction in cervical cancer, upwards of almost 90% in girls who are vaccinated prior to sexual debut. And so the reason that's important, you know, this is a prophylactic vaccine. We don't expect it to, prevent if a woman already has an infection. So in those older ages, do I think they reap the benefit of HPV vaccination? Of course I do. But again, we're talking about that methodologic aspect. If you're giving vaccination to older women, some have HPV infection, those will develop into cervical cancers. And in these types of studies, they tend to look like a vaccine failure. So when they focused on the younger girls, that's where they saw these really big estimates of cancer prevention. But having said that, I still think, you know, once you get these younger girls vaccinated, they are our priority, our primary cohort of interest. I think if there's enough vaccine, the benefits could abound from the others.
And Aimee, you know,
yes.
that really just underscores what you're saying, that when you see the power of this, and yet we are seeing so many developing countries not having access or not receiving this. I mean, that to me is like heartbreaking, you know, when you see that.
Absolutely. It's an inequity.
Yeah.
That's what Dr. Bruni was showing in the first meeting. She was saying, you know what, lots of countries say that they're vaccinating, but it's the, you know, that the smaller proportion of countries that don't yet have it have huge populations. Those are the ones that, you know, have so much cervical cancer. And so we're not making the impact where we need to.
But that's also because the screening is not great there, right? So it's a double whammy.
Nothing. Yeah.
Yeah.
Absolutely. Absolutely. I mean, let's face it, cervical cancer, we have the tools, we can prevent them. We just need to apply, you know, the vast majority, we need to apply these tools. And that's, I think, coming back to the single dose studies, that's where, you know, maybe that, you know, hopefully that's one of the answers that will help us get there. So anyway, we wrapped up our day with a late breaking session. Again, number of randomized clinical trials coming out. One that was really nice also to see was one by Dr. Karen Canfell, the COMPASS trial. That's an individually randomized open label RCT. And that's starting to look at the question of how do we screen vaccinated populations? And I think right now, you know, all of the screening that I'm aware of doesn't really account for vaccine status, but it's coming. These girls are aging in. And so we're going to have evidence-based recommendations will hopefully be able to be made based on trial data. So I thought that was great too. So that was my day. So exciting. Yeah.
Lots of fun.
I also have my.
So tomorrow we have another exciting day. We have 2 plenary sessions that will be fabulous. One on global issues, one on HPV infections in the head and neck. We have great basic science. We have great clinical science. We have great public health. We also have an update on HPV Awareness Day, or the HPV campaign, which will be fabulous.
Yes,
so
I can't wait.
You have to be there.
But I need a good night's sleep, so I'm gonna go.
Yes.
Okay, but it was so nice catching up after the day. I really enjoyed.
Yeah, it was good seeing you guys.
And we miss all of you. We'll see you in Kyoto.
Yes.
Cheers, everyone.
More fun
Have
tomorrow.
a good night. Thank you.
Bye.